So good afternoon, everyone. Thanks for joining me today. My name is Dr. Yisheng Cao. I'm one of the new spine surgeons here at the Lynchburg office for OrthoVirginia. I originally grew up in Canada, in Toronto. I did my undergrad at McGill University. I did my medical school in Michigan, did my medical training at the University of Illinois in Chicago, and my spine surgery fellowship at the University of Pittsburgh. I'm happy to be here at Lynchburg office and to serve the community here, and it's a pleasure to talk to you guys today. I want to spend some time talking about one of the more common pathologies I see in my clinic, which is lumbar stenosis, and what the treatment options are available for this condition, including the surgical ones that I can offer. So what is stenosis? I think it's good to start off with just a broad definition and understanding of what this is. It's basically a degenerative spinal condition that's caused by the narrowing of a spinal canal, which results in the nerve roots being impinged, and the stenosis can be either caused by a bony or soft tissue overgrowth that triggers irritation in the nerve. Notice that how I talk about degeneration, I like to talk about it as a maturity and wisdom condition. And so it's fairly common to see this condition in people, especially over 65 years old. Like I said, the causes of stenosis can vary. They can be bony or it can be soft tissue. In bony stenosis, is usually caused by arthritis or secondary to arthritis, where you have a slippage of the vertebrae on top of itself. As you can see on the X-ray image on the left-hand side, you can see that there is a shift between the L4 vertebral body and the L5 vertebral body. And that shift, I like to think of it as like a kink in the garden hose. The water in the kink doesn't flow very well, and therefore the nerves in the middle are getting impinged. Likewise, in soft tissue stenosis, you can have things such as like a disc bulge or ligamentum hypertrophy or a cyst that has grown within the canal that is hitting the nerve root and causing its irritation. So there's 3 different areas of stenosis that we can see in the lumbar spine: central, lateral recess, or foraminal. As you can see on the MRI image beside on the slide, the central stenosis is what, in the center part of what is labeled as the thecal sac. The lateral recess is on the side, and the foraminal stenosis is just on the outside of this canal. And usually, people suffer mostly from lateral recess and foraminal stenosis, which can cause what we think of as sciatica. There's various treatments for lumbar stenosis, and usually we start off with non-surgical management of these, because most of these symptoms can be managed adequately without surgery, and patients can achieve very good functional recovery and get along with their activities of daily living without ever needing to be on the surgical table. The first steps usually consist of a combination of oral medications and a course of physical therapy to train their core strengthening and balance and gait training. Oral steroids and as well as non-anti-inflammatories are also a good place to start. As you can see on the image there it's what it's showing is a disc herniation at the L4-5 level from the L4-5 disc, causing what is lumbar stenosis. Most of these disc herniations actually resorb and resolve by themselves, and we just have to help work together with you to make sure that your symptoms are well controlled as these disc herniations resorb by themselves. However, if these symptoms are persistent and these first step medications and therapy isn't helping, then we proceed with obtaining an MRI of the lumbar spine to get a closer look at the nerve impingement and the causes of the stenosis, and we can therefore recommend some injections, including epidurals or transforaminals, to see if that localized dose of steroids through injection can be helpful. Ultimately, as a surgeon, a lot of times patients come to me having done all those, and yet their functional activities and their activities of daily living are still severely impacted, and therefore, unfortunately, we have to talk about some surgical options. Like what I said, because it's if there's a kink in the pipe, or if there's stenosis in the pipe because of gunk that's built up in the pipe, it's a structural issue. And to solve a structural issue may require surgical decompression. Decompression means we go in there and we clean out the the elements that causing the stenosis, impingement of the nerve, and to free up the nerves from the stenosis. It usually results in better improvement of pain and functional activities compared to non-surgical management, especially when patients have failed the non-surgical treatment. There's a lot of times where I can do a decompression without requiring a fusion. A fusion usually means using instrumentations including metal screws and metal rods. However, we may have to consider the need for a fusion if there is instability that has been demonstrated on the MRI scans or the radiographic scans prior to surgery. In addition, if their stenosis is severe and I need to do a wide decompression, causing instability of the alignment of the bones, then therefore I may also have to recommend a fusion surgery. However, whether to decompress alone or the need to fuse is a personal decision, and usually it involves a very detailed discussion between me and you to find what the correct treatment and the most ideal treatment is for each individual patient. Of course, the surgeries I mentioned aren't the only surgeries that are available for spine pathologies. My pain management partners also do a plethora of other options, including using spinal cord stimulators or doing a limited decompression, or what they call a mild procedure. There are some interlaminar or interspinous spacers out there that have been placed on the market, as well as facet arthrodesis products that are out there. I'm happy to talk about those, and my pain management partners very well trained in those procedures as well. That's all I have. If you guys have any questions, I'm happy to answer them.
Thank you so much, Dr. Cao. So we are able to answer some questions now. We will be answering questions submitted earlier and questions that are submitted live. Not all questions will be able to be answered, but we will be able to get through some of them. Our first question is, how painful are those surgeries that you mentioned?
So the surgeries actually are very successful, and the pain itself is as bad as what most people make it out to be. If it's only a decompression without a need for fusion, I usually recommend about an 8-week recovery time. Patients may be able to actually leave the hospital on the same day without having to stay in the hospital overnight. Usually their leg pain, the pain that's caused by the nerve stenosis, is relieved right away after surgery. We see about 70 to 80% improvement of their symptoms. The back pain component is usually about 60 to 70% relief. So overall, these surgeries are very well tolerated. We use a good multimodal perioperative pain medication in the acute phase to get patients over the acute pain part of surgery, but overall, these surgeries are very well tolerated.
Thank you. Can scarring from prior surgeries affect getting treatment?
So scarring from prior surgeries definitely impose a greater challenge from the surgical technical perspective, because the scars from previous surgery may change the anatomy of the subsequent surgery and make it a little bit challenging from the previous in the surgeon's hands. But I've done multiple revision surgeries in the past, and I'm pretty comfortable with doing them. It shouldn't affect the recommendation or the treatment of what's going on. Usually we can work through the scar and still get very good results from the subsequent treatment or surgery, even though there was some prior work done.
Thank you. We've had several questions asking just kind of for some more details about that. So that one was about scarring, but we have people asking, if you've had a discectomy there, if you've had a fusion there, can you still get these treatments?
Absolutely. So a lot of work, I've done a lot of work in patients who have had prior discectomy and subsequently underwent further breakdown that level or recurrent disc herniation. I've had to work with patients who had previous fusions and subsequently developed a breakdown at the other levels that are adjacent to the previous fused level. These pathologies are common and they happen pretty frequently, and I see them frequently in my clinic. And again, it doesn't preclude them from getting surgical treatment or any non-surgical treatment. Usually we can get through these procedures pretty well.
Thank you. What are the factors that predict whether surgery will be successful?
So there's multiple factors that can be considered in terms of the success of the surgery. Usually patients do very well from surgery if they have had exhausted non-surgical management, including physical therapy, injections, and their activities are severely debilitated because of the lumbar stenosis. I think that is one of the biggest factors for a treatment success. Of course, we need to optimize all our patients, including definitely with my patients. I try my best to make sure that they're nutritionally optimized, they're medically fit for surgery prior, because all these are key factors to making sure that the patients respond well to the actual surgery and have a very smooth post-operative period.
Thank you. What is the recovery like after these surgeries? Is physical therapy required? And how long until you can do activities again?
Yes, so for the overall recovery of surgery, if it's a decompression-only surgery, I usually say that the recovery period is about 8 weeks. If it's a fusion surgery, if it's a primary fusion, it's usually about 3 months. If it's an extensive surgery that required multi-level reconstruction, then it can take up to 6 months in terms of recovery time. When I say recovery time, it's not the amount of time that the patient is, in the hospital or in rehab. It's the overall recovery time to get the full benefits of surgery. Patients are usually able to get up and walk from their bed the day after surgery with some physical therapy. Now, physical therapy is usually prescribed after surgery if it's needed. Usually, I do not immediately prescribe physical therapy after surgery. I let the body and the tissue heal, and I give it some time for the patients to recover from surgery. If physical therapy is needed, I will prescribe it, but usually it's at the 3-month post-operative mark. In terms of activities to be done, I usually let patients get up, walk with therapy, able to walk and do the activities of daily living pretty freely. I do limit them in terms of no excessive bending or twisting or lifting heavy objects for the first 8 weeks after surgery. But I usually try to mobilize my patients pretty fast. I try to get them back to their activities as fast as their body allows, and as I usually try not to restrict them too much. I'm also not a big brace user after surgery. I tend to rely on my instrumentation and my hardware to help the patient instead of prescribing bulky braces that can limit their activities after surgery.
Thank you. After a patient has healed from surgery and is back doing the activities of daily living, are there any long-term restrictions on things that they can or cannot do, especially things like sports or traveling or anything like that?
So usually the quick answer to that is no. I let the patients go back to basically the activities that they were trying to do or they want to do prior to the surgery. Now, of course, we can talk about some, extreme circumstances where if a patient's an athlete in a competitive sport that that includes contact, then maybe that there might be some restrictions on that. But for a general average patient who is active, who likes to play some recreational sports and who likes to go out, run or take a jog in the park, usually there are no restrictions on these activities after surgery, including if it's a fusion surgery. I think one of the common misconception is that a fusion will limit the range of motion and mobility of a patient. Usually a small, limited fusion in the lumbar spine actually is very well tolerated, and not many patients have experienced significant restriction in their motion after a single level lumbar fusion surgery.
Thank you. Do these surgeries require staying in the hospital? Can you give a little more information about what the decompression and the fusion surgeries look like sort of on surgery day?
Yeah, so if it's for a decompression surgery, usually the patient comes in about 2 to 3 hours prior to their surgery scheduled time. They get checked in at the hospital and they be brought up to the preoperative unit where I'll see the patient, I'll talk to the patient again, we'll go over what the surgery entails and what the expected course is. I usually make sure that the patient brings a family member with them whom I can update along the surgery. If for decompression surgeries, usually they're pretty fast. Usually, usually within less than 2 hours of actual surgical time. And the goal is to, if the patient is able to tolerate, to have the patient go home on the same day. However, if the patient is coming from somewhere that's far or is uncomfortable going home, there is an option to stay overnight at the hospital. But usually I try to aim to get these patients out of the hospital within the same day. For fusion surgeries, usually that means that for lumbar fusions, usually that means that I'll tell patients that may entail an overnight stay in the hospital, maybe 2 nights. That's mainly for pain control after surgery in the acute phase, as well as making sure that they can get out of bed with physical therapy before they're discharged from the hospital. But most times for decompressions, they can be done outpatient. For fusions, it's usually 1 or 2 nights of hospital stay.
Thank you so much, Dr. Cao. That is all the questions that we have for today. Would you like to close?
Sure, yeah. It was a pleasure talking to all of you guys. I hope to see you guys in my clinic if you guys need me. And I'm always available. My door is always open. Thank you.